In this second section, I'm going to be discussing etiologies of extracellular edema. It is important when you have a patient with swelling that you have a good understanding as to the reason why that swelling exists. Because while most swelling is related to a particular disease process, there are some types of swelling in which the lymphatic system is impaired and causes the disease of lymphedema itself. So I'll be focusing a lot on the physiology of tissue fluid exchange, and this will give you a good understanding in terms of why a patient has the swelling that they have. I'll start with a review of Starling's equilibrium. Starling's equilibrium basically says that under normal circumstances, there's a near equilibrium that exists between the capillaries and the interstitium, such that the fluid which comes out of the capillaries is largely balanced by the fluid that is either reabsorbed or removed by the lymphatic system. The four forces of Starling's equilibrium include the capillary pressure inside the vessel, and then plasma colloid osmotic pressure also within the blood vessel. So the plasma colloid osmotic pressure exists because of the attraction of water to proteins within the bloodstream. So anytime you have plasma colloids, think of proteins, and that absorbing pressure or the pull of the water toward the proteins creates an inward drawing pressure. Now there's two other minor forces in the interstitium. One is the interstitial fluid pressure, and that pressure is very minor compared with the capillary pressure on the inside of the vessel. And sometimes that interstitial fluid pressure can actually be negative. So it can be a few millimeters of mercury positive or negative. It doesn't play a major role, but it is necessary. It is a force which you need to understand. Similarly, there are some colloids or proteins out in the interstitium, and those colloids like to attract water just as the ones do inside the blood vessel, only because there are so many fewer colloids in the interstitium, that interstitial colloid osmotic pressure is markedly less than it is inside the vessel. So these are four forces that work together that pretty much balance the fluid inward and outward flow between the blood capillary and the interstitium. Then there's also the lymphatic drainage process to this. So we know that there is some residual fluid, waste products, proteins that cannot be directly reabsorbed back into the blood vessel. And so those properties are picked up by the lymphatic system. All right, so what happens when you have somebody with swelling? What is going on? And this can be answered in a number of ways. So the first thing is that if you have increased capillary pressure, as is marked by that large blue arrow on the left-hand side, if there's increased capillary pressure, it stands to reason that you're going to have more loss of fluid from the blood capillary out into the interstitium. All right, imagine then if you have decreased plasma proteins, and we will give clinical examples to all of these here shortly so that you can have a better understanding of what these disease processes look like. But if there's decreased plasma proteins such that you have a significant reduction in proteins within the bloodstream, you will not have that normal binding force to create a good colloid osmotic pressure in order to hold the fluid within the vessel. So the net result of this also is a fluid loss out into the interstitium. Third is increased capillary permeability. So anytime that blood vessel wall is more leaky, you're going to have a fluid loss. And because of the higher pressures within the blood capillary, that fluid loss will be out into the interstitium. And then finally, blockage of lymphatic return. So imagine that all four forces of Starling's equilibrium are normal, as we discussed a few minutes ago, but there's a blockage of lymphatic return such that those lymph vessels are unable in that particular region to remove the necessary fluid, proteins, and waste products. Then the net result will also be an increase in extracellular edema. So as you can see this with this list of 4 categories of conditions, that all of those may contribute to increased extracellular edema. And by the way, these would also be considered to be pathological conditions. All right, it is important to remember that excess interstitial fluid levels may result in tissue edema, but not all edemas are lymphedema. And I think that's important to understand. It's also important to understand the etiology for proper treatment. For example, if somebody has edema, marked lower extremity edema due to acute congestive heart failure, treating that patient for the swelling, assuming that they have lymphedema, and then proceeding to treat it, as we will talk about in section 3 of this class, but proceeding to treat it as if that patient had lymphedema can have serious life consequences. So it's very, very important when you see somebody with swelling to do a good medical history and to ask the proper questions and to get good medical diagnosis so that you provide the best form of edema reduction, if that's even within your scope of practice, prior to beginning your treatment to reduce their edema. All right. So nearly all edema is safely treated by PTs, except that from, and this is a short list, acute DVT. So as you're well aware, if you have a patient with an acute DVT, obviously the priority is on getting them to the physician for getting proper diagnosis, starting them on anticoagulation, and then managing potential edema as a result of that DVT. So certainly PTs may see patients with acute DVT, but only after diagnosis and onset of proper medical treatment. Acute infection, often edema will accompany somebody with an acute infection. If, however, you treat that edema, you potentially have the risk of spreading that infection. So that is considered a contraindication. Acute cardiac edema, if somebody has acute or uncompensated or untreated cardiac edema, that should not be something that is addressed by a physical therapist until the person has appropriate diureses and appropriate cardiac management first. And then if somebody has unexplained pain or swelling that has not been investigated, perhaps imaging has not been done, there's no medical explanation why that pain and swelling exist, those require adequate diagnosis first so that you don't potentially apply treatment and result in further harm. All right, so at this point, I want to take each one of those reasons for increased for increased extracellular edema and break those down and give them some clinical names. So the first one is increased blood capillary pressure. So in this case, we're going to look solely at increased blood capillary pressure as the reason for increased extracellular edema. So you might think for a minute, if you know of what might create increased capillary pressure, either locally or systemically. All right, let's see. So how many of you have thought of heart failure? So if you can understand, if the heart begins to fail, there's a backup of venous blood in that venous blood has difficulty returning back to the heart. And in process, then that increased venous backflow creates increased capillary, causes increased capillary pressure. If you think about the vascular system and how the arterioles merge with the venules with a little capillary network in between those two, when there's increased venous pressure, that pressure backs all the way up into the capillary network. And that's what gives you that increased capillary pressure. So certainly heart failure would do that and create a rather systemic edema. In acute congestive heart failure, massive amounts of edema can pool in the body. Typically, it's found in the lower extremities just because of the effect of gravity. And unfortunately, often accompanying heart failure will be kidney failure as well, only exacerbating the problem of holding on to that excess amount of fluid. Then in addition to a systemic cause of increased capillary pressure, there's also localized causes of increased capillary pressure. For example, deep vein thrombosis. In the case of a deep vein thrombosis, you have a clot. This is obstructing venous outflow. And when you obstruct venous outflow, you're going to have increased pressure backing up behind that DVT. So this similarly will cause some increased swelling in the area, in a regional area, whether it's the legs or whether it's arms. And this, again, needs to be recognized. And that's where your clinical evaluation and your medical history that you get from the patient will help you to kind of identify, could this be a patient with a DVT, which is, as you well know, a medical emergency. So simply you're evaluating this patient with edema and maybe other symptoms that are similar to a DVT might end up indeed saving this patient's life. So one other cause of edema from increased capillary pressure that we see very, very frequently in the clinic is that of chronic venous insufficiency. And with chronic venous insufficiency, you have valve failure because those veins become very dilated, the valves become insufficient, and instead of the venous blood flowing efficiently from distal to proximal back to the heart, those valves fail and some of the blood retrograde flows, creating a venous hypertension. So your patients with chronic venous insufficiency, and we'll see some pictures that will help you understand the presentation of that. Then occasionally we also have edema from increased capillary pressure caused from things like medications. There are many, many medications which contribute to increased extracellular edema. And if you think about it, if you have a medication contributing to increased extracellular edema, it's going to be rather systemic as opposed to regional. And then vasodilation from the heat How many of you perhaps have gone out and exercised on a hot day just to notice that things fit quite tightly, your rings fit tightly, a watch band fits tightly, and you just kind of feel swollen everywhere? It's because you have capillary dilation to try to bring blood to the surface and cool us off. So as a result, you get this increased capillary pressure. So this has given name to a lot of clinical scenarios which may potentially contribute to extracellular edema. Here's an example of cardiac failure, and just briefly I'll mention this individual. This individual came into our lymphedema clinic with quite swollen lower extremities. That picture on the left shows how he presented. He was a very slight, small man, so initially when you look at the pictures, it may not appear so much that his legs are swollen. He has some indents along the proximal legs. This is because he had a history of some congestive heart failure and had some chronic edema, chronic rather mild edema that he managed with the use of wearing compression stockings. Well, when his legs began to swell more, he contacted the doctor and said, hey, my stockings aren't working very well. I need new compression stockings. And sight unseen, in other words, the patient did not go into the doctor's office. The doctor just sent a referral for him to go back to the lymphedema clinic. So when I evaluated him and I saw quite abundant pitting edema from the feet up to the groin, even beginning to affect the genitals, I inquired about medications he was taking. I inquired about weight gain, and it turned out that compared with just recently, about 1 or 2 weeks prior, he was now 30 pounds heavier than he was just 1 to 2 weeks ago. And so that is a red flag for acute congestive heart failure. And indeed, what had happened that the patient was unaware of, and we were unaware of until I inquired about it, was that he had run out of some of his cardiac meds and his diuretics and had not gotten those refilled. And he was going back into acute congestive heart failure. So in that case, you do not treat this individual. This is a medical emergency. He needs to be seen by his cardiologist. Had I said, sure, we'll just go back into compression and issued new compression stockings or applied compression bandaging, we would have created a much, much greater load on the heart and potentially have killed him. So the right picture is where he has now seen the physician. He went back on his cardiac meds and his diuretics and lost a substantial amount of the weight that he had recently gained due to fluid. And at that point, then I was more than willing to fit him with new compression stockings to manage the chronic mild edema. Chronic venous insufficiency, I mentioned earlier, as being due to valvular failure in the veins. This typically is not a medical emergency, although certainly the doctor needs to be aware of it. This brown staining on the legs is due to hemosiderin, which is the extravasation of the some iron molecules and breakdown in the skin as that blood is forced from the vascular tissues out into the extracellular spaces. It leaves this brown staining. This is very typical of chronic venous insufficiency. So when you see this on somebody, you can be rather certain that they have some significant vein problems going on. This commonly also creates edema because of that extravasation of fluid from the vascular spaces into the extracellular tissues. Deep vein thrombosis, I mentioned earlier. This is a local problem. Again, it's like having a clog in your drain, and that venous blood distal to the clot cannot get out efficiently. And so it causes this rather abundant, soft pitting edema with often kind of a dusky look to the skin, sort of has a purplish cast to the skin. This, of course, is a medical emergency. You may address the edema after the patient has been cleared by the physician. Dependent edema is another reason that we see for increased capillary pressure contributing to extracellular edema. In this case, often what happens is a combination of the effect of gravity acting on the venous system and acting on the lymphatic system, and then coupled with the absence of good muscle pumping from the ankle and the calf. So all of these factors together create edema down in the distal legs and feet. And one final example is the edema following dialysis, fistula complications. So this individual has actually had a fistula inserted in the cubital fossa for purposes of dialysis. And when that is done, there's a reconstruction, so to speak, of the arterial venous system, which puts more effect on the venous system. And so in essence, you end up with a little bit of the edema that you would see from a DVT, although it's from a different cause. So this is directly related to his dialysis fistula. All right, so let's put increased capillary pressure aside as a reason for extracellular edema production and talk about decreased colloid osmotic pressure. So anytime you have decreased colloid osmotic pressure, we're talking about within the blood vessel. And you have to ask yourself, why does that person have reduced protein concentration? So the following are some clinical examples. It may be caused from loss of proteins in the urine or the stool. Sometimes people have severe digestive problems in which they are losing large amounts of proteins in the stool. In cases where you have patients with large areas of burns or wounds, in addition to loss of fluid, they also lose a considerable amount of proteins through that fluid loss. And so these patients are placed on very, very high protein level diets. And then you have some where there's just insufficient protein consumption. For example, in an area where somebody is not obtaining the necessary nutrients or does not have enough to eat, or sadly is self-imposed by the disease of anorexia. You may also remember that the liver is the chief organ of protein production in the body. And when somebody has liver disease, whether it's cirrhosis, whether it's a malignancy, but advanced liver disease, the liver is unable to produce the necessary proteins. And typically, one cannot eat enough protein through our food to account or make up for our liver not producing enough proteins. So any of these reasons may cause somebody to be hypoproteinemic. So that's actually a disease process. So here's a few cases. This individual had hypolymphatic protein-losing enteropathy. That's a mouthful for you. So this was a patient I saw for a number of years. She actually had primary lymphedema, and we talked about that in our last section. Primary lymphedema is where during fetal development, the lymphatic system doesn't form effectively, and those transport vessels or those collectors are insufficient. So, number one, she had insufficient transport of fluid out of her legs. So as a result, she had chronic swelling in her feet and her legs. But then she also had insufficient development of the gastrointestinal lymphatics. And as you remember, those gastrointestinal lymphatics are very important for picking up proteins and fats and taking them through the cisterna chyli, through the thoracic duct, and emptying them back into the venous angle, back into the bloodstream. And this individual was losing large amounts of those essential nutrients. As a result, she, on occasion, would actually need to have an aspiration of fluid from her belly because she had this proteinaceous fatty fluid which just deposited third spaced basically in the abdomen rather than going into the bloodstream. And so as a result, not only did she have lymphedema in her legs, but it was exacerbated by the fact that she had hypoproteinemia or low protein levels. Individuals with this condition can actually be placed on a special type of diet in which they consume largely medium chain triglycerides. There are medium chain triglyceride diets, and the benefit to those is that medium chain triglycerides are easily picked right back up within the bloodstream, and they don't need to be picked up by the lymphatics. So as long as she ate fats of a medium chain length, she was better nourished and had higher protein levels. Anytime you do see somebody with hypoproteinemia related edema, stop to think is that it would be systemic because you certainly aren't hypoproteinemic in one area of your body and not in another. But because we live on Earth and, during the daytime, we're in the gravity assisted position, the edema tends to be worse in the lower extremities. Also, because the protein level is very low, the nature of that swelling is very soft and pitting. So people who have accumulated fluid over quite a short period of time, but it's a large amount of fluid, the tissues will be very, very soft and pitting. And upon removal of the pressure from your finger, that pit will readily fill back in. So keep that in mind in terms of a characteristic of edema from hypoproteinemia. All right, now we're going to put deficiency in plasma colloid osmotic pressure aside, and we're going to talk about increased capillary permeability. So, what do you remember about physiology, particularly about wounds, which remind you of increased capillary permeability? And I'm hoping that you think of these. So, allergic reactions, tissue injury, bacterial infections, and burns. So let's first talk about allergic reactions. So whenever you get a bee sting, whenever you get a mosquito bite, and perhaps even an allergic reaction from medication, isn't there usually some swelling associated with that allergic reaction, whether it's systemic or whether it's local? So that's part of the histamine reaction causes us to swell. A little bit similarly is tissue injury. And what we're describing here is that all-important inflammatory process. Remember, the inflammatory process is a good thing. It sets into stage healing and tissue recovery. But in the early phases of the inflammatory process, you do have increased capillary permeability for the purposes of fluid exchange and hormonal exchange, etc. And then bacterial infections. You have probably all seen somebody who has had an infection, particularly maybe a skin infection. We know of as cellulitis. Accompanying those infections will be edema because of the increased capillary permeability. And burns is also somewhat in that same category. So here's a busy slide, but it's just a reminder of why edema and the signs of inflammation show up at the time of tissue injury. So when you have tissue injury, you have arterial dilation and capillary permeability, as we just talked about. You have increased blood flow. And then obviously that escape of capillary fluid out into the interstitium. So all of this causes swelling and causes redness and causes heat because of that marked increase in blood flow. But then along with that, you have all those hormones and enzymes released, bradykinins and histamines and prostaglandins, and all those things that cause us to have pain, cause us to have more swelling, and those are also indicators of tissue inflammation. Now, in addition to edema presenting out in the interstitium, you also have some temporarily impaired lymphatics in that region, because what happens is thrombin comes in, those thrombin fibrin plugs come in to plug up the capillary to keep the bleeding from continuing to happen, but it also plugs up the lymphatics. So early on, those little lymphatics are impaired as well. So you kind of have a double whammy. You have more tissue fluid going out into the interstitium with a reduced effect of the lymph drainage, taking that fluid away. All right, here is an example, and you've seen this fellow before because we saw him in the first section. This is the fellow that had the bike car accident. So at the time of his trauma, he obviously had the inflammatory process was set into play, causing the initial reason for the swelling. And then every time he had an infection, every time he had more surgery, he had more and more swelling and more harm or scarring to the lymphatics. So when you have somebody with musculoskeletal impairment, a musculoskeletal injury, always think, okay, the swelling is natural. That is going to happen. But how can I minimize the effect of that swelling on delaying that person's recovery? So in this case, the swelling kept him from wearing a shoe because it didn't fit. It reduced the range of motion in his ankle. It certainly exacerbated the existence of the wounds for a year, and probably contributed to ongoing inflammation and infection. So ask yourself, once you know that he's safe to treat, once you know that the fracture is stabilized, once you know that he does not have an active infection or an active DVT, it is absolutely essential that you do what you can to help reduce his edema, because it will rapidly improve his recovery. Here's another example, not quite as drastic as the last one, just even a simple ankle sprain. So PTs, you're going to see patients with sprains and strains. What's the first thing that comes to mind after injury? And I'm hoping the first thing you say is get screened by the physician, perhaps have some imaging done, because you want to rule out fracture. You want to rule out anything serious. Once that has been done, the best thing you can do for this individual is instruct them. What are some things that you learn as PTs? You learn elevation. You might learn some massage. We will talk in this third section today about managing edema with a special form of massage. Application of compression. The application of ice to control further swelling. So definitely there are things that you can use early on to, again, limit the pain from that swelling and limit the harmful effects from the persistence of that swelling. All right, let's look at our fourth reason for increase in extracellular fluid. So we're going to assume now that the patient has normal capillary pressure, the protein levels are normal, and there has not been any recent trauma to suspect increased capillary permeability. But for some reason, there's reduced or eliminated lymphatic drainage. Perhaps that patient had a cancer history and some of the lymph vessels or lymph nodes were removed or damaged. And for some reason, then that removal of property from that local region has been impaired. I talked about primary lymphedema and secondary lymphedema actually in section 1. Remember, primary lymphedema is a congenital absence or malformation of lymphatic vessels. Secondary lymphedema is where that individual is born with a normal, healthy lymphatic system, but later on develops a disease process in which those lymphatics are harmed or removed. Speaking of this, so in the United States, certainly cancer is a major reason for secondary lymphedema because cancer surgeries, which may remove lymphatics, followed by radiation, which may damage lymphatics, are certainly a significant contribution to secondary lymphedema. But we're realizing now that perhaps the greatest contribution to secondary lymphedema in this country is chronic venous insufficiency. It is epidemic. As people become more sedentary, they may be in jobs where they stand a lot. Certainly the obesity rate is rampant, and with obesity comes a greater risk of chronic venous insufficiency. So this is a condition called phlebolymphodema. And we will see a picture of this shortly. So these pictures you've seen before of primary lymphedema. I don't think at this point I need to go through again as to why they're swelling because we've talked about that previously. Secondary lymphedema. These are some stats. Depending on the reference that you seek, you will see statistics all over the place in terms of its the contribution to the cause of lymphedema. For example, that last one, in breast cancer cases, you have from 6 to 30% of patients that have undergone breast cancer treatment end up with lymphedema. Well, 6 to 30% is a wide range, and you see ranges even wider than that sometimes. It depends on many, many factors: how aggressive the cancer was, how aggressive the surgery was there breast conserving surgery or not, and how many lymph nodes were removed. So there's many, many factors that enter into that. I will address the top one, 750 million with filariasis and 15 million with chronic changes. Filariasis looks like this. So filariasis is basically a disease which is carried by a mosquito. The mosquito injects basically a parasite into the skin, which goes into the bloodstream. And from the bloodstream, because that parasite has an affinity for protein, it goes into the lymphatic system and scars the lymphatics. So they renders them basically ineffective. And while this disease, filariasis, is not a disease present in the United States, it is endemic in some portions of the world, some third world countries. And unfortunately, families and communities of patients with filariasis will exist. And fortunately, there are now medications which can kill the parasite. Their health organizations, their national health organizations, are finding more and more ways to eradicate this problem with the mosquitoes. But nevertheless, once the damage is done to the lymphatic system, the only course they have is to be treated for their lymphedema. And yes, those limbs, as terrible as they appear, can be treated. Absolutely, they can be treated. But again, these are in some of the poorest countries of the world where medical resources are lacking. Traumatic lymphedema. This individual I saw a number of years ago who had a motorcycle accident, and it actually injured the lymphatics right along the medial knee. And as you recall, those lymph collectors, those strings of pearls, so to speak, are fairly straight, and they go up from the feet through the legs. They kind of merge along the medial aspect of the knee and then course up the medial thigh up to the inguinal lymph nodes. And what happened in this individual's case was he had quite a deep scar across the medial aspect of the knee, which you obviously cannot see because of the lobe there, and it caused an obstruction in the lymphatic system. And as it caused that obstruction, then the skin just stretched and filled up with fluid, and stretched and filled up with fluid. It was unfortunately exacerbated also by the fact that this individual is obese. With obesity almost always comes a greater risk or greater difficulty managing lymphedema. So let's discern a little bit between edema and lymphedema. Now, unfortunately, you will hear many people who talk about, oh, all edema is lymphedema. And I guess this is a difference of opinion, but my stance is all edema is not lymphedema. It is only lymphedema when it adversely impairs the lymphatic system. So edema is a symptom of a disease. So you're playing basketball and you sprain your ankle on the basketball court, and it swells soon, maybe within an hour, within a couple hours. Well, the lymphatic system, as I mentioned previously with the inflammatory process, sure, it's impaired regionally for a bit of a time, but there's not true lymphedema there. Basically, the swelling is because of the increased capillary permeability. Think about the patient with acute congestive heart failure. That fluid is accumulating because of those increased venous pressures as a result of a failing heart. That individual's lymphatic system is working. It's working just as hard as it can. There's nothing wrong with the lymphatic system. It's just that there's too much fluid flowing in to the tissue spaces to be able to be removed at any particular time from the lymphatics. All right, and also typically edema many times is a low protein concentration. Now it may be high or low protein, but generally speaking, often edema is a low protein concentration because as you recall, the lymphatic system for the most part is doing its job. And that one of its jobs is to remove the proteins from the interstitium. So the lymphatic system, when it's functioning, it's removing proteins from the interstitium. So generally speaking, you don't often have a high protein concentration edema. Also, the tissues are able to kind of disguise a certain amount of increased tissue edema until it gets to about 30% or greater, and then it will present as most likely pitting edema. Lymphedema then is a distinct disease. It's the name of a disease due to impairment in the lymphatic system. And here you have abnormal tissue swelling due to mechanical insufficiency of the lymphatic system. So here's not necessarily that there's an onslaught or a sudden increase in fluids being poured into the interstitium, but rather a lack of removal of that fluid through the lymphatics. And because that lymphatic system is broken down, mechanical insufficiency, think of it like as a car broken down. Because that lymphatic system is not functioning, that's why you end up with a high protein edema when that lymph system fails. Now, what's the big deal between, is it high protein or low protein? Low protein edema will always be soft and pitting in nature. High protein edema leads to certain physiological changes in which the proteins gradually become very fibrotic within those tissue spaces, and the resultant effect is induration or brawny edema, where it may be very difficult to actually pit that skin. For example, the cases of filariasis that you saw a few slides back, you can imagine from looking at them, they're just as hard as a rock. So there's tissue fluid there, oh yes, but there's lots of fibrosis. And most likely, if you went and pressed your thumb into those tissues, they would not pit easily or at all. How can you tell the difference? Lymphedema, high protein swelling, we talked about that. Formation of skin hardening, and that is progressive, doesn't happen instantly. Deep skin creases exist, particularly at the joint areas. And with lymphedema, it's unilateral, or if it exists bilaterally, it will be worse on one side than the other, and typically comes on somewhat slowly. Whereas edema, if edema is bilateral, it's going to be symmetrical, unless with the exception maybe of injury or surgery. And often it is low protein and soft and pitting, and it has a rather definable onset. You sprain your ankle, the swelling starts. Acute congestive heart failure, the swelling starts. Liver disease, if they have enough hypoproteinemia, the swelling starts. With lymphedema, it's more insidious. How can you tell the difference? Well, you absolutely want to rely heavily on the patient history and their presentation, because that patient, along with the availability of information from the EMR, will give you an idea in terms of just what is going on. Look at their labs. Look at their imaging. Does it look like a venous problem? Do they have a history of cancer surgery where some lymphatics were removed? Does that sound like a lymphatic problem? Do they have some sort of organ dysfunction? Do they have a recent medication change which may have triggered a retention of fluid? So a lot of it is an investigative work. So do your good medical history, do your good clinical evaluation, and many, many times your good heads, along with your education, and this list here will give you a pretty good idea in terms of why that edema is present, and are you the one to treat it, which often you are, or does it take an interdisciplinary measure? And by all means, if there's any question, contact the physician and get information first, or perhaps refer them back to the physician. Remember, no treatment by you, PTs, if there's acute infection in the area. That requires a referral back to the physician for antibiotics. Acute DVT, which has not been treated first with anticoagulation. By the way, acute DVT, often compression is encouraged. Mobility is now encouraged. But that's not a substitute for getting the patient medical care first. Acute cardiac edema, this is differentiating from stable congestive heart failure, and acute pain or swelling. Get any of these checked out by the physician first, and then if the edema management is warranted, feel free to progress with treatment. All right, so that's the end of section 2. I'm going to take a little break right now, and then we'll come back and go over our third section on assessment and treatment of lymphedema.